Thank you, Gina, for that kind introduction, and I wanted to thank the Society for inviting me to come and speak today. I also wanted to start by acknowledging the traditional owners of the land on which we meet and acknowledging their elders past and present. And so I've been asked today to come and talk about motor neuron disease and non-invasive ventilation, and I'm aware it's a really varied group. And I'm aware that you'll probably have really varied interactions previously with non-invasive ventilation, by which I mean bi-level CPAP therapy mostly. And so I've tried to hit a sweet spot of not giving you too much detail, but giving you enough detail. And I don't know how I'm going to go, so I'm a bit worried about it. So we'll just give it a go. So there's the overview, and this slide comes up again and again so that you've got a bit of a place marker for where we are in the talk. The very first bit is just a little bit about motor neuron disease, which, as we've heard, is really an umbrella term for a progressive neurodegenerative disorder that may affect any part of the neuromuscular system, may start with hands and feet, usually one side more than the other, or may start with bulbar symptoms of trouble swallowing and trouble breathing. The etiology is unclear. The picture there is of the MCG full at finals time, and hopefully the Swannies are going to make it this year for me. And I put that there because there's about 100,000 people that fit into the MCG when it's full. And about 1.5 to 2.7 people per 100,000 per year are diagnosed with MND. That's the incidence of it. And the prevalence of it is higher. That's the number of people living with the disorder in any one point in time. So that just sort of gives you a sense of that it's a relatively rare disease. We see at Campbelltown Hospital about 1 a year, perhaps, people that actually present with respiratory failure as the presenting symptom of their motor neuron disease, and it's always something that's on my mind when someone presents with respiratory failure for no particular other reason. So it's a very rare occurrence in my professional life. So why am I here? What's a respiratory doctor talking about motor neuron disease? Because I'm not a neurologist. I'm not very good with the tendon hammer. Why am I here? And I'm here really because of respiratory failure. Respiratory failure occurs in motor neuron disease. I couldn't find any sort of good numbers about the incidence or prevalence of respiratory failure. And I've just got a bit of a note there about respiratory failure, that the causes of respiratory failure are really an inability to get air in and out, and also an inability of gas exchange. And in motor neuron disease, it's really an inability to get air in properly because you get weakness of the respiratory muscles, particularly the accessory muscles of respiration. Respiratory failure is always worse at night. Whenever it occurs, regardless of the cause, it's always worse at night. And in motor neuron disease, that's probably because the main muscle of respiration we use all of the time. And when we're awake and alert, we use all of the accessory muscles, the sort of muscles of our shoulders, muscles of our chest. But when you go to sleep, particularly in dreaming sleep, in REM sleep, the body normally turns off all of those other muscles, and you're reliant on the diaphragm. And the diaphragm can be weakened from motor neuron disease, and if you're relying on this muscle that's a bit weak, it means that you're not going to breathe so very well. And that's why it's often worse at night, and why the main therapy that's directed for it that I'm going to talk about today is used at night predominantly, and then, as many of you might have seen, progressively used during the day. There's one randomised controlled trial that supports the use of non-invasive ventilation in motor neuron disease, and there's a number of cohort studies, and the one RCT that was done suggested that it prolonged survival and that it also improved quality of life, though I think that the evidence on which this device is used is still flimsy. I'm not sure that we're going to get any better though. So then, what is this NIV business that I'm talking about? So NIV is any form of ventilation that can be delivered without the use of an endotracheal tube. NIV has been around for about 20 years now. It was invented initially as CPAP, which is continuous positive airway pressure, by a Sydneysider, a fellow by the name of Colin Sullivan, who worked at Prince Alfred, who really developed it for use with sleep disordered breathing, with obstructive sleep apnea. And he literally got an anaesthetic mask and a backwards vacuum cleaner and put it on these people, and that was literally how he developed it. I'm going to talk a bit in a minute about the difference between CPAP and bi-level CPAP. But bi-level CPAP is the technology that's used in motor neuron disease. And I'm going to refer to non-invasive ventilation, and some people might mean both CPAP and BiPAP. If I say non-invasive ventilation today, or NIV, I mean just BiPAP. Because that's the only technology that's of these two that's appropriate for motor neuron disease. And I'm also a little bit lazy fundamentally, aren't we all? And BiPAP is a brand name. It's one of the particular brand names of the particular machines that are made, but it's much easier to say BiPAP than bi-level CPAP. So I'm going to do that. I don't necessarily just mean that brand. The nice VPAP people and the other people are just as nice and have lovely machines. This technology, bi-level CPAP, may be used to treat nocturnal respiratory failure. And in the acute hospital setting, I suppose there are probably some people from the acute hospital setting here, it may also be used in acute respiratory failure, mainly due to acute exacerbations of COPD, but increasingly due to other causes. So there's some pictures. Your eyes aren't going funny. That one in the middle is a little bit blurry because I had to sort of scroll it up a bit. There's a few different things there. This is a very typical looking BiPAP machine. This is the sort of compressor machine bit at the back, and the bit here at the front is a humidifier that's used to moisten and warm the air so that it's not quite so drying and quite so annoying when people are using it. This machine down here is one of the very fancy pants ones that they use in the intensive care units, but really not appropriate for home use. It's more these ones that are for home use. And these are a couple of different sort of interfaces that can be used. And you can see the nurse here putting the mask on the patient there. Almost always in motor neuron disease, it's a full face mask, so a mask that goes from above the bridge of the nose down underneath the lips. In sleep apnea and things, we'll often use a nasal-only mask. The nasal-only masks are almost always not appropriate for motor neuron disease because people with motor neuron disease have weak jaw muscles too, and their mouth drops open and you get air leaks, so you're trying to push pressure in through the nose and their mouth opens, it comes straight out through the mouth, so we almost always use a full face mask. There are some people that really can't stand them and we need other tricks, but that's the way I'd start. Oh, nice blank slide. No, there we go. So I wanted to now move on to talking a little bit about the differences between CPAP and bi-level CPAP. So both use a mask as an interface, and with both of them you may add oxygen into the circuit, though that's usually not necessary for motor neuron disease, but sometimes necessary for some of the other reasons that we might use either of these technologies. The crucial difference between these two technologies is that CPAP has a single pressure throughout the respiratory cycle, whereas BiPAP, as the name might suggest, has two different pressures, a higher pressure at inspiration and a lower pressure at expiration. And so as a consequence, if there's something that's blowing air into your respiratory system, just have a think about it for a minute. It's going to be hard to breathe out against. And if it's already hard to breathe out because your respiratory muscles are weak, that's going to be fairly crap for you if you've got motor neuron disease. But it's quite useful if you've got sleep apnea and a range of other disorders. Bi-level CPAP is easy to breathe out against. There's only one mode in CPAP. But in bi-level CPAP there's two different modes, and I'll talk a bit more about those in a minute. So the way that no, I'll talk about that when I get to the next slide, I think. So essentially, CPAP is terrible for motor neuron disease, whereas bi-level CPAP is good. And if you sort of miss some of the distinctions, that's one of the crucial messages. BiPAP is good, CPAP is crap for motor neuron disease. And really, if anyone is trying to put CPAP on your motor neuron disease patients, beat them over the head, because they will do terribly and they will be turned off the technology forever, and it's really a dreadful, dreadful, dreadful experience. They did it to one of my patients and I had to remonstrate strongly with someone. So I talked about there being two different modes, and the two different modes are called, not very creatively, spontaneous and spontaneous timed. They're both the same in that they've got two different pressures, an IPAP, which is for inspiration, and an EPAP for expiration, so inspiratory positive airway pressure and expiratory positive airway pressure. And now might be a good time for me to say that the pressure is usually measured in centimetres of water for reasons historical, and the usual sorts of numbers depends a bit how big and fat people are, but for a little skinny motor neuron patient, I'd usually start at pressures of sort of 8 and 4 would be my usual sort of starting place. And if they're a bigger person, you'd need a bit bigger pressures to overcome their upper airway pressure. But there's two different pressures. In spontaneous mode, the transition between the higher breathing in pressure and the lower breathing out pressure is entirely triggered by the person breathing. And there's some fiddles that you can set with the machines about how sensitive that is. But what happens in spontaneous mode is that the machine is sitting at the expiratory pressure. The person breathes in and so-called triggers the machine, and that means that the machine goes up to the inspiratory pressure, up to the higher pressure. And that, if so long as there's an airtight seal, that will push air into the lungs. And then the machine keeps the pressure at that higher pressure for a predetermined period of time. There's a few different ways that the technicalities about how you can set the machine, but usually for a predetermined period of time it'll hold it at that pressure, and then it lets go of the pressure and or the patient breathes out, and the machine drops in pressure back to the expiratory pressure and allows them to breathe out. The difference between those two numbers is called the pressure support, and the bigger the difference between the two numbers, the bigger the breath you're going to take in, and so the bigger the breath you can take out. In contrast, in spontaneous timed, as the name might imply, there's a different transition. And the transition between pressures may be triggered by the patient and may be entirely triggered by the patient, and that's when it's operating just in the spontaneous mode. So exactly as I've described. But in addition, if the patient doesn't take a breath for a predetermined period of time, the machine, in inverted commas, breathes for them. So you'll usually set a backup rate on the machine when you're in spontaneous, well, you'll always set a backup rate in spontaneous time, that's the point. And say you had a backup rate of about 15, because that makes the maths nice and easy for me. So 15 breaths per minute is what you've said to the machine. This is the minimum number of breaths I want this patient to take. And the patient's breathing along and breathing along and breathing along. And then if they don't take a breath for 1, 2, 3, 4 seconds, the machine says, oh, well, if we're going to have 15 breaths per minute, I need a breath every 4 seconds. So it delivers a breath. And the machine then transitions from the expiratory pressure to the inspiratory pressure, and therefore makes the patient breathe. And that's the critical difference between them. What have I done next? Spontaneous mode is really not at all useful in motor neuron disease, but spontaneous timed mode is much, much more useful. And that's because, particularly when people go to sleep with motor neuron disease, their muscles are weak, particularly in REM sleep, and they don't even have enough breath to trigger that transition in the machine, and they essentially stop breathing, particularly during dreaming sleep, and to a lesser extent during non-dreaming sleep. And so they need the machine to breathe for them, particularly in dreaming sleep, but also in non-dreaming sleep. And so almost all patients with motor neuron disease should be on bi-level CPAP in spontaneous time mode. All right, so that's the sort of technical bits about what NIV is. When and why would you consider starting it? And I think the main reasons to consider starting it are when people are sleepy, or they've got other sleep-related symptoms of morning headaches, or if their bed partner is worried that they're having witnessed apneas. The other indication that we often use it for, really without any evidence whatsoever, is for breathlessness, particularly orthopnea, for which I think there probably is evidence. So, you know, when people get breathless when they lie down, that's often a sort of sign about motor neuron disease. That they get breathless when they lay down, because when you're standing up, all of your abdominal contents are pulled down by gravity, so your diaphragm doesn't need to work so very well. But if you're lying down, then your diaphragm needs to push against your abdominal contents, and if your diaphragm's weak for whatever reason, motor neuron disease, then it's much harder to breathe when you're lying down. So I'd start it with symptoms, and morning headaches are a suggestion that people are having sleep disordered breathing and getting hypercapnic, building up CO2 overnight, and therefore developing morning headaches. The lung function test, the classical teaching is to start to consider non-invasive ventilation when their forced vital capacity measured by spirometry is less than 50%. There's a lot of contention about that, but that's the traditional teaching. You can also measure a thing called MIPS and MEPS, which are maximum inspiratory pressure, maximum expiratory pressure. I don't know that they particularly help you to decide when to start motor neuron disease, but they can be helpful for me in making the diagnosis. The textbooks talk about doing supine spirometry. So when I do spirometry normally, it's usually with people sitting or standing. The textbooks talk about doing spirometry with people lying down. Never done it. Don't really know. And I guess a patient request, because patients are increasingly informed about the possibilities and the options that are around, and they occasionally request starting on it because they've read about it on the young people's intertubes. I think, though, it's important to pause to think about why you might not start, because I've talked about this technology, I've talked that it might prolong life and that it improves quality of life, so why might you not start it? And I think these are things just to pause and reflect on. There's often quite a bit of caregiver burden, and there's always the question about prolonging life in the setting of burdensome symptoms. And I think that's an important thing to sort of discuss with patients who are considering starting this technology. And I'll go on to talk a bit more about that. There's difficulty with mask fitting. The masks are a bit cumbersome to put on, and I didn't really show it, but they sort of go on over your head, and there's a bit of headgear and things like that. And you need a bit of sort of manual dexterity to be able to either clip them in or do the Velcro up or things like that. And that can be troublesome for people that have got weak limbs. The cost is not that great, depending. The machines themselves cost $5,000 to $7,000, but mostly you can get a government-funded machine, though there can be a number of hoops to jump through, and it can be extraordinarily annoying to deal with the nice people from Enable, particularly in a time-sensitive disease. But there's no way to fund the masks, and the tubing and things like that cost about $300 or $400, which is not a consideration for some people, but a substantial consideration for others. So having talked about that, how would we start non-invasive ventilation? I think really it's appropriate to involve your local sleep physician or a sleep clinic, and someone preferably with a bit of an interest in motor neuron disease. At the hospital that I work at, the neurologists know that I have a bit of an interest in this and send the patients to see me in my clinic. In order to get an Enable machine, it's a bit of a palaver and sometimes involves a whole lot of fighting, and involves me on the phone a lot, and some colourful language sometimes. But you need to document nighttime respiratory failure. The way to start with that would be to do a morning arterial blood gas looking for hypercapnia, a CO2 greater than 45, or you could look at a venous bicarbonate, because the body doesn't at all tolerate high CO2 for a long time because it makes the system acid, and the response to that is to make your kidneys pump out more bicarbonate, so an elevated venous bicarbonate suggests that there might be some underlying respiratory failure. The Enable people say that you need to have a sleep study, and there's been a bit of an internecine war about that. And the latest ACI guidelines say that overnight oximetry is sufficient, and the Enable people have been saying, well, go and get ACI to change it. And so now ACI's guidelines say overnight oximetry is sufficient. The Enable guidelines are yet to change, but we'll see. I think before starting non-invasive ventilation, it's essential that discussions about PEG feeding have been considered, because really, if you're going to put in a PEG, they need an anaesthetic, and if they need an anaesthetic, they need an FVC of better than 50%. So if we're getting to the point of starting non-invasive ventilation, I think the PEG discussions need to have been had. I don't think there's a right answer to that question at all, but I think they need to have been had. And then how do I figure out what pressure to put them on? I gave you my sort of guesstimate pressures, and essentially that's what I do. I kind of look at the patient from the end of the bed and go, yeah, you're about this big and you probably need about this, so we'll start with these pressures. You can do a sleep titration study in a sleep centre if I'm having trouble, that's what I do. It's really variable about people's practice about hospital admission for acclimatisation. It can be a real palaver to get used to the mask and how the mask fits, and it leaks and it wiggles and it goes, and where do you put this and how do you put all of that together? So sometimes a short few day admission to a hospital, preferably one with a sleep lab, that has an interest in doing this can be helpful, but that's a barrier for some people because time is limited and they don't want to spend it in hospital. And for people from rural areas, I think that's a substantial issue, and I don't know how to get around that. How to start? I really feel passionately about advanced care planning, and I think that advanced care planning when starting this technology is absolutely mandatory. And I think it's important to have a good discussion about the potential benefits and harms, about the idea that, which perhaps some of you have seen, is that people become increasingly dependent on their motor neuron disease, on their non-invasive ventilation as time goes on. They end up using it more and more through the day, and then they're on it really all the time during the day. And I think that's a really difficult thing to do. And then it's impossible to have a conversation with them when they're on their non-invasive ventilation all the time. So I'm adamant that these conversations have to start early and be done at the beginning. That said, I think my respiratory colleagues are not as good as they might be at having those conversations, and so I'm afraid that I think that often those conversations fall to their motor neuron disease workers. I don't think that's right, and you know, when I run the world I'll change it, but until then we're stuck. I think it's appropriate to discuss the idea of weaning non-invasive ventilation, particularly in the setting that people become dependent. And I also think it's worth having a talk at the outset that says, look, this technology can be helpful for some people, and let's see how it goes for you. Let's see if it works for you. But if the burden becomes greater than the benefits, we need to talk about that and we can stop. And I think it's important to empower people to think that they can have a choice about whether they continue with this technology or not. The other thing that I think is worth discussing is what to do in the setting of a chest infection. It's not infrequent that people with motor neuron disease develop chest infections, and whether intubation has been discussed, whether they discuss the idea of having a tracheostomy, whether that's something they may or may not want down the track, and if they did develop a chest infection, about whether we should continue using the NIV or whether we should take that as a sign that everything is too much for the body and allow them to drift away naturally. Difficult conversations. So what are the problems? Fitting the mask can be a palaver, particularly if you've got a funny shaped face, and particularly as people waste and they get muscle wasting in their face. The masks can get increasingly leaky, and they're not cheap, and sometimes you need to buy a new one. For taking the mask on and off can be difficult. Often sort of getting the mask on when people go to sleep is sort of okay if they've got a carer or they've got a partner or someone that's with them at home. But if they wake up in the middle of the night and need to take the mask off, that can be a consideration. I came in right at the end there, the lady was talking about dry mouth, but often people have wet mouth with motor neuron disease, and there's this question about aspiration and whether there's a risk of aspiration. My practical approach to that is to talk to the patient about risk if they've got wet mouth and talk about the benefits and burdens. In places that don't have a really fantastic electricity supply, where there may be blackouts, it's appropriate to think about generators or things like that, or how they'd get the mask off if their hands are weak or increasingly weak, how they'd get the mask off. Pressure areas can develop, particularly across the bridge of the nose, and it's appropriate to keep looking for that. It's uncomfortable, and it can be quite a burden to the carer to be doing this all the time. And I think that, you know, considering the carer burden in this is something that certainly hasn't received any attention that I can find in the research literature. So, next question is when to stop. Goodness gracious, that isn't an easy question. Google supplies me no answers about it. So I think the times to stop are when the benefit is not worth the burden. When the patient, you know, feels that this is just too much of a hassle, and they say, look, I'm just over it and I want to stop. And I guess that, you know, then patients might request it for any other reason. But the other time to stop is when people are clearly dying. So, thank you. Now we're up to how to stop. It's easy if the patient decides, just stop. No weaning, no changing the pressures, no nothing. They say they want to stop, just stop. And if they want to start and stop and start and stop, that's fine by me. But, oh goodness gracious, how to stop if they're dying or if they're NIV dependent? Well, you thought the last question was hard. I think that this is one of the biggest challenges in motor neuron disease. Not that there are, you know, any small number of things competing for that title. So how to stop if they're NIV dependent? I went some years ago, not in the setting of motor neuron disease, but in the setting of acute exacerbation COPD, to find out how to do this. And I discovered that there was no evidence. And there are no published guidelines that I could find anywhere. There are some published guidelines about stopping ventilation in a setting of invasive ventilation in the intensive care, but I'm not completely sure that they're particularly evidence-based either. So the sort of, you know, it's a bit of a motherhood statement, but clear communication I think is essential, and I think it starts when NIV starts. And I think it's important to say to make sure that the people around the bed understand, because often the patient's in no position to participate in this conversation. But to understand that people won't die as soon as the NIV is taken off, that's a very common misapprehension. And it certainly hasn't happened in my clinical experience. And I think it's appropriate to anticipate symptoms and provide appropriate treatment, be it pharmacological or non-pharmacological. So the next slide is just what I reckon. And I'm happy to have debate about, quite whether this is right or not. So I think carefully titrated doses of opioids and or benzodiazepines is appropriate in this setting. I think about the dose of morphine is about 15 milligrams per 24 hours via a syringe driver, but that is if people are opioid naive and they're sort of reasonable frame, and often they're quite wasted by the time the end comes, and so the dose may well need to be lower. And of course morphine may or may not be the right agent depending on kidney function, previous reaction, blah, 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 blah. There'd be discussion about whether midazolam should be included in that. I think it should, but it's my personal opinion, and I'm certainly happy to hear arguments otherwise. Some people believe in supplemental oxygen in this setting, some people don't. I kind of think if it makes people feel more comfortable, it's fine and it's worth a trial. I think a fan is a really useful intervention for dyspnea. Semi-recumbent I think is important because I talked about how people's diaphragms are weak, and if they're sort of sitting up a bit it gets some of their abdominal contents down. My view is that the syringe driver should be started and then probably a breakthrough dose given and then remove the mask with careful monitoring, and if people are clearly really uncomfortable, put the mask back on and try again with another breakthrough dose. I think in very, very severe cases perhaps terminal sedation is indicated, but I think that's a sort of question that different palliative care physicians would have different views about. So in conclusion then, people with motor neuron disease may well develop respiratory failure due to respiratory muscle weakness, particularly at night. Bi-level CPAP certainly has a role in treatment, and that role is evolving, and while there's some evidence for it, I think that there are some cogent reasons to consider before rushing into it. I think the clear communication is absolutely essential, and knowing when to start can be tricky. Knowing when to stop can be harder, and actually stopping, I think, is the real trick. So I might have a